Before the Pacific data, we had limited options for patients who had unresectable non-small cell lung cancer. We made progress by figuring out that concurrent chemoradiation is better than sequential chemotherapy radiation. Unfortunately, not a lot of our patients can get concurrent chemoradiation because of the potential toxicities. We looked at different doses of radiation, and by we, I mean the oncology community, not me personally, of course, at the use of different doses of radiation, addition of different drugs to chemotherapy backbone, using consolidative chemotherapy after the concurrent chemoradiation was completed, but none of those really had any meaningful impact on the survival of the patients. And in fact, unfortunately, some of them were associated with higher levels of toxicity. So before the Pacific data, we were limited to concurrent chemo-RT, followed by a couple of doses of sort of what we call big dose or systemic doses of chemotherapy, depending on the regimen that was used. And the patient would have gone under a period of observation, which would have been, a regularly scheduled CAT scans and office visit to see if there is evidence of recurrence. So there really wasn't a whole lot more for us to offer to these patients after the initial chemo-RT. The use of chemotherapy along with radiation, again, has been investigated. Over decades, we've had chemo regimens such as the use of cisplatin and etoposide as one potential regimen, use of weekly carboplatin paclitaxel as another regimen. There have been arguments for and against the use of a regimen such as etoposide, where you can use almost full doses of both drugs, thinking that full doses of chemotherapy drugs would give you better systemic control, versus a lower dose of weekly carbopaclitaxel, followed by systemic doses of both of these agents, again, to achieve higher levels of systemic control of the disease. I think there have been a couple of head-to-head comparison studies, at least one in particular, where the choice of chemotherapy didn't seem to matter much in terms of improving PFS or overall survival of patients who were getting concurrent chemo-RT. Toxicity, however, was clearly different between different regimens used. The rates of esophagitis and other toxicities could be different based on the choice of chemotherapy that one uses. In the case of a patient with adenocarcinoma, another regimen that was investigated was the use of cisplatin and pemetrexed. And again, that regimen was not shown to have superior overall survival, but toxicities were a little bit different. So from the perspective of improving clinical efficacy endpoints, the choice of chemotherapy didn't seem to matter as far as I'm concerned. In a patient who has a squamous cell carcinoma, the options are, again, the weekly carboplatin paclitaxel, such as the one that this patient got, versus using the cisplatin etoposide. Obviously, the use of cisplatin in someone who's a little bit older, lower performance status, maybe compromised renal function would be a little bit more difficult, but with active care and follow-up, it is possible. So I would say most practitioners, and me included, would choose a chemo backbone that we think our patient can tolerate in terms of toxicities. So to some level, it has to do with the clinician's comfort level with the particular regimen, and to some extent, what a clinician thinks that a patient can tolerate in terms of the toxicities associated with particular regimens. But all of these regimens appear to be equally effective when combined with radiation. Majority of the patients who get concurrent chemoradiation will have some response. Radiation is very effective in local control. Chemotherapy acts as a synthesizer to radiation and also as having direct cytotoxic effect. So majority of patients who receive chemotherapy and radiation have a response. The question is how durable the responses are. Obviously, there are side effects associated with both treatments, such as development of esophagitis that makes it a little bit difficult for patients to swallow for a few weeks. Most of these are transient, but obviously a patient requires active support through these kinds of events. From time to time, obviously, again, use of chemotherapy radiation can be associated with hematologic toxicities such as neutropenia, anemia, that are manageable. But clearly, if somebody's neutropenic, administration of chemotherapy, especially if you're using a weekly regimen, might not be possible or feasible. So there are clearly issues like that that one needs to pay attention to. If I use a weekly regimen, I see my patients every other week, basically, sometimes on a weekly basis, depending on how much side effects they have and how much concern I have for them in terms of tolerability. Obviously, while they're getting daily radiation, they are being monitored, and there are nurses and physicians who see their patients on a regular basis. So I think we can pick up these toxicities and try to manage them. But from a response point of view, I think majority would end up having a response. A lot of my patients do get fatigue, so they do require a little time to recover. And I think these are all issues that most oncologists and radiation oncologists who use these regimens are familiar with and monitor their patients for. But it's not the easiest regimen for physicians and patients to go through. But again, as I said, it tends to be highly effective, at least initially, in terms of regaining control over cancer that's growing aggressively. Patient who's neutropenic, obviously we hold chemotherapy. We don't use growth factor support during radiation because that's obviously contraindicated. Very rarely at our center do we hold radiation unless a patient is very, very sick, requiring hospitalization, febrile, and issues like that. Esophagitis is one of the major issues. Again, we're trying to manage that by going over pain management with the patients, using proton pump inhibitors or other means to control any potential reflux disease, instructing the patient as to the kind of diet that they can have to get them over the period of esophagitis. It's a little bit variable from patient to patient, and the severity also varies, again, depending on the kind of chemotherapy that one is using. But over the years, we've managed in a sort of a multidisciplinary team approach to manage the pain and the esophagitis and issues like that. Occasionally, patients can develop pneumonitis, although I have to say I haven't seen someone develop rapidly progressing pneumonitis during chemoradiation, but theoretically something like that could happen. That obviously poses significant issues in terms of how to complete the regimen and the course of treatment. Hematologic toxicities other than neutropenia, if there is significant anemia, we usually manage that with transfusions. Obviously, a patient who is febrile, it's hospitalized with the usual precautions that we use for a febrile patient. For nausea and GI side effects, again, we're fortunate to live in a time where we have really good antiemetics for the management of these patients. The one that's most difficult for me to manage and to help my patients is the fatigue. And I think we try to encourage our patients to remain active as much as possible, but for some patients, the fatigue is, I would say, affects their quality of life a little bit more than anticipated. And again, that is one of the more difficult side effects of this particular regimen for patients to tolerate.